Good afternoon. Thank you to everyone for being here today. I want to welcome you to UCSF Family and Community Medicine Grand Rounds. We have a fantastic session today, and I can't wait for us to get started. But just a few quick housekeeping reminders. First, today's session is being recorded. Since this is webinar style, we'd really like it to be interactive, and we would strongly encourage you to use the Q&A to ask questions or share your comments for us. If you have suggestions for the speaker today or speakers today or for future grand rounds, please use the evaluation sheet that we'll put a link to during the session to share your thoughts and suggestions with us. Also, if you missed part of today's grand rounds or you want to see it again, or you'd like to see previous grand rounds that we've had, you can find all of them. They're all uploaded onto YouTube by looking for the UCSF Family and Community Medicine website. Just search under grand rounds and you will find all the sessions. And they're fun to watch. I want to thank, before we go any further, our fantastic tech team today. We have Erigo Mitchell, we have Benjamin Wallen and Roy Johnston helping us out. And I also special thanks today to Linda Apellis, who made us our brand new, very exciting Grand Rounds backdrop. Our session today is entitled Caring for Trans and Gender Diverse People, Evidence-Based Medicine Across the Lifespan. And our session today will be led by Maddie Deutsch and Sen Huynh. Today's session is really focused on a very special topic. Trans and gender diverse people need access to quality health care. This gender-affirming care can include medical or surgical care to align one's body with their identified gender, as well as access to a full scope of medical care that is respectful and culturally grounded and acknowledges gender identities as valid. Recent political developments have added an additional layer of complexity to the barriers to care and disparities faced by this vulnerable patient population. In today's talk, Dr. Deutsch will review current evidence in selected areas of gender-affirming care for children, adolescents, and adults of all ages. I'm very pleased to welcome Dr. Maddie Deutsch today. Dr. Deutsch is a professor of family and community medicine at UCSF and the founding medical director for UCSF's Gender Affirming Health program, a multidisciplinary group of medicine, surgical, and behavioral health providers for trans and gender expansive adults at UCSF Health. Maddie is co-director for the UCSF School of Medicine Differences Matter initiative and a DEIB Co-Lead for UCSF Health. Dr. Deutsch has authored or co-authored more than 50 peer-reviewed journals and articles in the field of sexual and gender minority health, as was a co-author and primary care chapter lead for the recently released WPATH Standards of Care in the 8th version. She's also the current president of the UCSF Professional Association for Transgender Health. I'm also really thrilled to have Dr. Sen Huynh join us today. Dr. Huynh is an assistant professor in the Department of Family and Community Medicine and a family doctor who provides comprehensive care for patients of all ages at UCSF Health. They aim to form partnerships with their patients, creating a space where individuals and families feel heard. They have particular interests in trauma-informed care, gender-affirming care, health equity, and reproductive health. Before joining UCSF as a core faculty member, Dr. Huynh worked in a small community health center in Western North Carolina, providing comprehensive care for patients of all ages, regardless of ability to pay. They are a member of the World Professional Association for Transgender Health, and Dr. Huynh will be leading the Q&A session today. So please type your questions for Dr. Deutsch or Dr. Huynh into the chart. I want to thank you so much for the presentation today and hand it over to you, Dr. Deutsch. Thanks.
Thank you, Margot. It's great to be here. Hi, everybody. I'm really honored to have been asked to give this talk, so I will jump right in. Let me get my slideshow started. Here we go. Great. And let me just hide this, hide meeting controls. There we go. Great. Okay, well, it's really an honor to be here. And what I thought I would do just to start out is just kind of tell you where we are now. This is our facility. We're kind of an outpost. Sometimes I think maybe we're a little bit off the radar of the mothership FCM over at the General. We're at 1725 Montgomery. I can see Fisherman's Wharf from our window. And we have, beams and brick. It's a nice place. So come over and visit us sometime. And there's some more of our brick behind me here. We have a program website, transcare.ucsf.edu, that has a lot of detail about the services that we offer, as well as the members of our team, and also how to do an experience here if you're a learner. Med students and residents, we have opportunities for folks to come here. And the current status of our program, some of our, not really get into it, but we have some challenges getting some program data. So we have some slightly obsolete figures here because it takes a while to get updates. But looking back several months back, we had about 1,500 patients in care, about 900 of which were seeing us only for specialty consults, and they have PCPs elsewhere. And our catchment really goes from Washington State to the border with Mexico and well into Nevada. I'm licensed in Oregon, and then we have we even tell patients there's a rest stop at the border near Reno and near Las Vegas, and patients can drive their car and sit in a parking lot and do video visits from the state of California there. So we see patients from far around, and a lot of them are specialty only, but we do have a solid core chunk of patients for whom we provide primary care as well. So right now our team is 2 PCPs, myself and Dr. Wynn, who's with us. And Dr. Wynn and I offer both primary care as well as specialty only care. And then we have a adult ped double board endocrinologist who's finishing her fellowship here at UCSF, is joining us in September. And she's primarily going to be focusing on young adults and patients who are aging out of the UCSF Child and Adolescent Gender Center. In this particular time window of June through January of this past year, we had 163 unique genital surgery consultations, and our genital surgery service just got launched in 2021. So we're really cranking. And we have a team, includes a nurse manager, a social worker, a new patient navigator, LVN and MA. We have 2 MAs, one is a supervisor. And we have a number of standing collaborations with a range of departments throughout the health system, including some of which are embedded and see patients here at our Montgomery facility. We also have, as I mentioned, a learner rotation. We have a bunch of different research opportunities and activities that are going on, and we're developing more infrastructure in that area. And we also host the UCSF care guidelines, which are accessible through our website, and we get 10,000 hits per month on that set of guidelines. So they're very widely used. They're very comprehensive, and you might find them helpful. So how did we get here, as David Byrne may have once asked, if anybody are Talking Heads fans. So I'll give you just a very quick history of how I wound up doing what I'm doing. Well, let me go back before I tell you about this grungy building and then these 2 nice buildings. So I'm residency trained and board certified in emergency medicine. And after working 2 years post-residency in a busy urban large volume trauma center in Los Angeles, I became very frustrated with the lack of access to primary care. I was doing a ton of primary care in the emergency department because nobody had primary care. This was before the Affordable Care Act or anything. And I found myself just generally frustrated with the state of health affairs. I also, through my personal experience as a trans and queer person, knew that access to quality care for the queer community was really limited. So I took inspiration from a couple of different people I knew from around, and I also had a friend who was core faculty at the Ventura Family Medicine program, and where the family medicine runs the ER there. And I said, hey, a lot of ERs are run by family medicine, so it wouldn't make the door can swing both ways. And an ER doc is doing a lot of family medicine in the emergency department can certainly hang up a shingle. So that's what I did. I spent a ton of time at the UCLA Medical Library, reminding myself about some preventive healthcare things, and also doing a ton of research on what was available at the time on transgender health, and said, hey, I'm familiar with cradle to grave care, with access, caring for everybody regardless of who they are or how they identify. And I'm also really comfortable, as our family physicians, in basically dealing with whatever's thrown in front of us, no matter what. And so I feel like these trainings, these backgrounds that we have really prepare us well to do this work in transgender health. So I rented a suite, an office in this dingy building at Kings Road and Santa Monica Boulevard in Los Angeles, in West Hollywood. If you're familiar with the area now, it's a fancy pants building there, but in 2006, it was like a DUI school and a leather belt maker and a video editor, a hypnotherapist, and me. We were the building. And I opened this little kind of hole-in-the-wall primary care hormone therapy practice. It got very busy very quickly. And I moved into this fancy downtown Los Angeles building and was there for a couple of years. I got on the radar of the Los Angeles LGBT Center, which was working on becoming an FQHC in addition to their existing HIV Ryan White clinic. They brought me on to help them finalize the FQHC process and also launch a gender affirming health program there, which I did launch and run for 4 years. And through that work I got some research funding and I gave a couple of talks. I got on the radar for some powers that be at UCSF and ultimately came to UCSF and did some academic work, and then also launched the program that we have now. So that's how I arrived to where I am, and that's how we got to where we are. And the department certainly has been incredibly supportive over the years and couldn't have done it without the department. So thank you. And Kevin Grumbach was also very instrumental in the early days in getting this pushed through. So now let's kind of get into the meat of the talk. This is what we're going to talk about. First, we'll start out with just some demographics and social determinants, and then we will touch on the political and legal situation. I'll talk a little bit about SOGI data and taking a sexual history. We'll touch a little bit on the care of youth and elders, and then we'll talk briefly about the general approach to hormone therapy and some cardiovascular considerations. So the Williams Institute at UCLA is a policy think tank that really is the place to go when you're looking for demographic data relating to the queer community. And they're kind of the recognized gold standard in this area. So their most recent publications, they have a series of interactive maps that you can look at. But this is the estimate of the population size of transgender people in the US, so 0.5%. So a very non-trivial size of the US population are transgender. In the past, there had been numbers floated around of, it's like 1 in 30,000, 1 in 100,000. Those numbers were very skewed and they were not obtained through population level studies. So this is a really very accurate estimate. And then for youth, you'll notice that their estimate, and it's based on the Youth Risk Behavior Survey as well as other data sources, 1.4%. So let's look at that for a minute. Is there something in the water? Is there something happening with like TikTok? No. What's happening is that there's been a secular change in society where not only is it become more kind of acceptable and understandable to be trans, but language exists. So many people who I see say, when I was a kid, I didn't know anybody else thought like I did. So this is not something in the water. There aren't actually more transgender people in the US today than there were in 1950. It's just that we have the language to describe it, and it's a thing. So people are saying, oh yeah, that's me too. I didn't know that was a thing. So probably we'll see this figure go up a little bit more over time, but we're kind of getting to saturation because there have been a number of youth studies over the recent years that have been done that are finding this kind of like 1.5% range figure. So what are some of the social determinants that affect transgender people? So, the top 2 lines really describe the core of what's going on with trans people. So discrimination, which is tied into things like stigma and shame and trauma. All of these things interact with each other. So I think that we're probably all familiar with the effects of stigma and on a range of health behaviors and health outcomes. And there's no different when dealing with the trans community. So there's a great deal of institutional and structural discrimination, as well as just kind of day-to-day casual and even unconscious discrimination and unconscious biases. But stigma really cuts across a lot of this. And there's also an association between the denial of gender identity and high-risk contexts. And actually, someone who used to be at UCSF, Dr. Sebelius, described this model of gender affirmation that describes a direct linkage between denial of gender identity and high-risk behaviors that, in the way they described it, just drove an increased risk of HIV in the population. But you really could translate that to increased high-risk context of any kind. And that's all tied together. So there are high rates of not just emotional, but also physical trauma. There are high rates of intimate partner violence in the community. There's a lot of survival sex work, and it's always important to remember that survival sex work does not just mean working on the corner and getting work and passing cars and making cash. Survival sex work can be staying in an unhealthy relationship because it meets certain needs, or provides for certain like shelter or food or protection, or for emotional connection, even if it's an unhealthy one. And then there are a range of other issues, many of which are rooted in some contexts and states, lack of legal protection, so unstable housing, lack of housing or employment protections, and lack of general legal protections. And a lot of this really results in high rates of incarceration, not just from sex work, but when you're dealing with stigma and shame, you're engaging in high-risk contexts, there's high rates of behavioral health issues that are often untreated because of the mental health crisis in this country and lack of access. All of this ties together into things like substance use for self-medication, or getting involved in shadow economies that involve, I guess, arguably criminal activity that results in people being put in jail. So the whole kind of incarceration complex interfaces with the trans people and the factors that trans people live with as well. So let's talk a little bit about the political context. I mean, you'll notice the dates on some of these headlines I'm sharing here are extremely timely, right? So you've probably noticed in the news, it's just been a tennis match of this state passes a law, this state law gets overturned, this state passes a law, this state's law gets stayed by a judge. So right now we're in a very intense time. None of these laws are grounded in any kind of reality. They're all political machinations for people who are seeking to achieve political gain, need to always have a boogeyman. And in the past, the boogeyman have been everything from, communist filmmakers in Hollywood to immigrants to Muslims to, gay people who want to get married. So now the boogeyman is trans people. And unfortunately, this one looks like it's sticking a little better than some of the, all of those boogeymen still exist also, but this new one that they found, trans people being the boogeyman, and when I say boogeyman, I mean like the scapegoat. But trans people becoming the scapegoat, we're a very small and disempowered, disenfranchised population with, and it's very easy to scapegoat us. And there's unfortunately been a lot of push from certain more progressive circles back against the trans community, especially when it comes to youth care too. So there's some strange bedfellow stuff going on there. So I want to show you, there's a couple of resources here if you want to screenshot this. This is a great live resource that keeps you kind of up to date on what is the political map state by state. And so it's a very fast moving target right now, and something to keep on your radar. The Federation of State Medical Boards actually has a tracker out now to help track changes and various state level actions. So something that you can use to inform yourself. So now let's pivot away from legal and let's talk a little bit about SOGI data. So when we talk about SOGI data, we're talking about sexual orientation and gender identity data. So this includes a bunch of different things. It includes gender identity as well as birth assigned or recorded sex. Now, I want to explain to you why we have to record at least 2 data points, and typically the birth assigned or recorded sex is what's recorded. The reason is that a good chunk, and data kind of consistently shows it to be somewhere between 25 and 35% of transgender people say, I just identify as male or female. I don't identify, my gender is not transgender female. My gender is not transgender. My gender is not non-binary. My gender is female. If you only ask people, are you male, female, transgender female, or non-binary, 25 to 30% of the population are going to say, well, I'm female, but there's no way for me to indicate that I'm trans. And then what will happen is when you try to evaluate your data, or you're trying to do some kind of population health work with your data, you will lose that 25 to 35% of the population. They'll be subsumed into what is presumed to be a cisgender population. And that's not great when you have a small population because every single person that you lose it reduces your power to make any kind of meaningful analyses because the population is so small. So recording birth assigned sex allows you to say transgender people are people whose birth assigned sex and gender identity are different. There are other rubrics being developed, including one that I'm kind of looking at without getting into too much detail on that in the scope of what time we have time for today. You have to ask more than one question is kind of the consensus. And this two-step method is the current standard. Sexual orientation is really a multiple dimensions. It's not just are you gay, lesbian, bisexual, pansexual, queer. It also has other dimensions like what kind of attractions do you have, or what kind of sexual behaviors do you engage with? What are the organs of your sex partners? Because if you ask somebody just what is your sexual orientation and they say I'm a lesbian, that doesn't really tell you much with regards to their contraceptive needs, because if that patient's partner is a trans woman who's still able to make sperm, then you might want to talk to them. If that person says that they're heterosexual, but their partner is a trans man who doesn't make sperm, then they may be tired of being asked all the time, do you want to talk about contraception? So it depends on what you're looking to gather. So there's lots of different dimensions here. And also really importantly, SOGI data includes someone's chosen name and pronouns. And it's so important to record name and pronouns for a bunch of different reasons, but most importantly, to respect people for who they are. But there actually is data also that patients, when they're called the wrong name or pronoun, they're going to leave clinic. And then you've lost the opportunity to link them to clinic to take care of whatever health needs that they may have. So why do we need to collect SOGI data? Here's a bunch of different vignettes that I'll present to you, and hopefully that will paint the picture. Primary care wants to know if there's a disparity for flu vaccine by sexual orientation. If you haven't measured sexual orientation data, then you have no way to make the two groups and make the comparison. The emergency department wants to know if the left without treatment rate is higher for transgender people. Are trans people experiencing discrimination in the waiting room? Are they being misnamed or pronounced at the front desk? Can't figure that out if we don't know who the trans people are. The health system wants to know if sexual or gender minority populations are more likely to be lost to follow-up system-wide. Same thing. Another one could be if an investigator wants to submit an NIH proposal and they want to look at HIV-related cancer outcomes, they have to submit preliminary data and kind of like a planned enrollment table of how many people do you think you're going to be able to enroll of different sexual behaviors and orientations. If you don't have the ability to pull those numbers, then you can't submit the table. And then that can actually be a cascade to a research disparity, because the NIH is going to say, we're not going to fund this research because you don't have enough preliminary data to support the submission. A patient just wants their provider to know important aspects of their life and care needs. And just because we're all committed to diversity, inclusion, and advancing health equity. So these are all really important reasons to collect this. And this is what I wanted to show you. Here's a qualitative study of experiences of trans people reviewing their own health records. So, nowadays patients can just read their chart, and they do read their charts. So number one theme that came up was that using the wrong name or pronoun or gender marker for patients is common in the EHR, and it erodes trust and causes trauma. It's actually a traumatic event to be mispronounced even in your written chart, so it's important to remember this. And when you move on, for folks who are in residency and you're going to go out and become a medical director for a clinic, this is really good argument to support developing programs and services that are inclusive and that have workflows that are well thought out for these needs. How do we collect SOGI data? This is from a study that I did actually to kind of look at how do patients want to provide this information, because a lot of times the reflex is, well, we want to get as much of this as we can, so let's get it collected at the front desk when the patient checks in. But that's a really chaotic and public place where interactions are very casual and not particularly intimate. And in our study, patient preferences, and this is from when I worked at Women's Health, and so we had a mix of genders and sexualities. Patients pretty much universally and in a multiple analysis, the preference for method of collection didn't vary by gender identity, sexual orientation, age range, socioeconomic status, or the speaking of a non-English language at home. everybody really wanted to provide the data anonymously, either by a pen and paper form, or most of them by some kind of electronic device in the waiting room or an online portal. And very few people would prefer to have the front desk or a kind of like a rooming nurse. And if people, had to have it collected person to person, they want it by their medical provider. So we're actually using this data to guide the implementation of SOGI workflows across the health system, which has been an ongoing project I've been involved with for a number of years. So let's talk about, how do you take a sexual history in order to enter some of that data? When I was in medical school in the late 90s, this is what they were teaching us, and I think they're still teaching this a lot of the time. Do you have sex with men, women, or both? And the real question, is this ideal? And does it tell you everything that you need to know? And obviously, it doesn't. It doesn't tell you everything because you don't know if the men or women you're having sex with, what kind of organs they have. And then both implies that there's only these or this or that. And it negates and renders invisible those who have non-binary gender identities that are neither male nor female. So this is in a paper that I wrote, and this is the kind of model this is the approach that I use, and I created this theoretical model to describe it, which is the onion model for taking a sexual history. And I like to peel the onion. Now, the take-home message here is that we cannot say we're doing complete SOGI data collection and sexual history taking unless we're taking a sexual history on everyone. Because if you only take a sexual history on people who you think have sexual histories that are not cis heteronormative, you're going to miss people. And you're also going to not be able to make those comparisons again. So we have to find a way to take a sexual history that lets you be able to get a sexual history that is detailed and appropriate for a polyamorous radical queer fairy patient of yours who you want to get all the details, but also be able to take a sexual history from your 77-year-old kind of Tagalog first language, heterosexual cisgender patient. So sometimes I take a sexual history over the course of several visits. You might just ask questions like, are you a sexual person? Do you have a sexual orientation? Some people use a term to describe their sexual orientation. Are you sexually active? We ask these questions to better understand our patients. We ask these questions of all of our patients. It's our standard policy here. You don't have to answer them. It's just something we ask everyone. A question that I want to ask, and again, we ask everybody this question. Some people have more than one sexual partner. May I ask if you have more than one sexual partner? And then you can kind of just continue and eventually get down to things like, and do you have, what organs are involved in taking in your sexual activity? Okay, so the next thing I want to talk about is the World Professional Association for Transgender Health. Margot mentioned it during the introduction. So WPATH, World Professional Association for Transgender Health. That's like the AAFP for transgender health. It's the professional society, and it's an international society. There are some regional and national chapters. So there's a US chapter, and I'm the president of that chapter currently. WPATH publishes these standards of care guidelines that are very comprehensive. The most recent version came out in September. As Margot mentioned, I was the lead author for the primary care chapter. The document goes into a great deal of detail regarding everything from how to properly assess people prior to initiating hormone therapy, including youth assessments prior to surgery, gender identity development, primary care, hormone therapy. It's a very comprehensive document. It's about 200 pages long, and you can access it for free from wpath.org. So if you hear me referencing WPATH guidelines, that's what it is, and I recommend you take a look at it and at least be familiar with it. So let's talk now a little bit about the approach to trans youth, and I'm going to reference back to WPATH. I'm going to really digest this down into like a 1 minute, 1 slide kind of thing. This could be an entire series of lectures. So I may have some colleagues who are in the audience for this talk who do this work, and I, respect the work greatly that you do. Just I'm boiling this down to 1 slide because we just don't have a lot of time. Prior to Tanner stage 2, And this is all aligned with the WPATH Standards of Care. Prior to Tanner stage 2, there's nothing medical going on. So we hear a lot of gesticulating in the news about, oh, 9-year-old kids are getting hormones. There's no 9-year-old kids that are getting hormones. You have to be a Tanner 2 before any medical interventions would be considered. Prior to Tanner 2, you're talking with the family, maybe the child is using different pronouns or name or wearing different clothing or expressing themselves in different ways. But it's not until puberty begins that you would think about using any kind of medication. So when a child gets to Tanner 2, pubertal suppression is appropriate with a GnRH analog, usually leuprolide, but there's other GnRHs that are used. There's an implant that goes in the skin and lasts for a couple of years. And then if developmentally appropriate and situationally appropriate, you can start hormone therapy as well. So if there's an 11-year-old female assigned person who is at Tanner 2, that's probably not the right time to start testosterone. So you'd probably have them on a blocker for a couple of years, and then when they're 13, 14, would be a time to start taking testosterone. The GnRH analogs are really good to kind of pause. If there's a child who's kind of freaking out because puberty is coming and they are very trans, but maybe there's a parent who's not on board, or we're waiting until we move to a new state, we want to start to a new school, parents are divorced, mom lives out of state and is not supportive of the hormones, but maybe will support just pressing pause with the blockers. We have a lot of experience for years and years with these blockers for kids, cisgender kids with precocious puberty. So there's nothing really new or experimental about this. It's safe and it really works well. I have some outcome data that I'm going to talk to you about in a moment. Surgery under 18 is rare. And we don't have a great deal of data on this, but I'll tell you that it's rare. The exception is really chest surgery in transmasc youth. It can be really difficult to move through the world as a male if you have a large and visible chest. And the alternative is very painful binding, which can be very uncomfortable and also can restrict physical activity, which we're going to talk about in a moment because that's an issue in this population. So chest surgery is, I wouldn't say common, but is done from time to time in kids under 8, in kids maybe 15, 16. General surgery is very rare under 18, and it's usually like a kid who's like 17 and a half and is going to college next year and like wants to get their surgery done before they go off to college so they can just not have to like deal with that and not have to take a semester off to recover. They want to do it like the summer before college starts. So it's not, if it's being done on somebody who's 17, it's usually for like situational reasons in very clear-cut cases. So some of you may have seen that there's been a lot of kind of in the news, coverage of detransitioners and people with regret. Those are extremely rare cases. And it's been turned into a political wedge issue, but the actual prevalence of this is pretty rare. I'm going to show you some data actually. There aren't specific age cutoffs in SOC8. It's really left up to the individual provider. But there are some requirements and qualifications for doing these assessments. So these assessments need to be done properly. And I'm actually chairing a quality task force through USPath to develop some recommendations for quality assurance in the approach to these evaluations. And we have an excellent panel of experts that we've assembled for this. People doing these assessments do need to have training in child identity development, gender identity development, and need to be people who are appropriately qualified. And it really should be an adequate team-based approach. Now, the double bind arises in that there are areas of this country where there's no access to that kind of care. There's just no provider available or insurance doesn't cover it. And so that's actually a challenging situation that our task force is actually working on, trying to come up with some recommendations of what do you do when you literally cannot follow the best practices and you have a child sitting before you. What are the courses of action? And so that's something to be thought about. So let me talk to you about some outcome data. There has been a relative paucity of outcome data regarding pubertal delay in kids. There's a large multi-center trial. UCSF is one of the sites that is currently in progress. This is some kind of initial data that they've released. And I don't know if I can't see all the attendees, but I know Dr. Rosenthal messaged me last night that he was maybe going to be attending. So if he's here, shout out to Dr. Rosenthal, who is the medical director emeritus of and founder of the Child and Adolescent Gender Center here at UCSF, and an expert and good friend. And so what they're looking at here, I'm just going to kind of do a little bit of evidence-based medicine and also give you a couple of tricks to kind of wade through dense data like this. Let's just spend 30 seconds on this slide and move on. Don't worry about the data points. These are the regression lines. So basically what they're looking at is scores of appearance congruence, score for positive affect, score for life satisfaction, score for depression, and score for anxiety. So you can see here that both for kids who initiated early puberty, who initiated hormone therapy in early puberty, and kids who initiated hormone therapy later in puberty, things are actually improving for both groups in general. There are some differences between people who started early and late, and some of that makes sense. So like appearance congruence for people who started later in puberty, they had lower initial appearance congruence scores, but then actually they got so happy with the way that they looked that they actually passed the scores for the kids who started hormone therapy earlier in puberty. So the later in puberty kids are kids who maybe had some of those changes already occur. And were less happy about, maybe they were 10 or 3 or 4. And then, you can see that positive affect actually got a little bit worse over time with the kids who started hormone therapy early in puberty. It's hard to say what secular trends exist. Kids are living in a pretty unfriendly world for trans kids right now. So there's other factors that could be driving this as well. But life satisfaction really went up too. Depression scores went down. Anxiety went down for the kids who started late in puberty, but not early. Again, there's so many other things that can make kids anxious. It's hard to say. So we have some preliminary data that has some definitely suggesting some good trends. And that's on top of a lot of anecdotal data we have doing this a long time, knowing that this stuff really works. So this is risk of suicidal ideation. This was a study actually done. Jack Turbin is also here at UCSF in child psychiatry. And so they actually looked at from a large database of the US Transgender Survey of adults aged 18 to 36 and asked them to kind of recall previous treatment. So it's a recall bias potential. But you can see here, and so let's do a little quick evidence-based medicine. How do you look at a slide in 30 seconds? So look at the p-values. They did a nice job of putting a star here. So let's look only at the ones where the p-value is statistically significant. So you can see here, compared to, this is a group of people who received pubertal suppression when they compared to people who did not receive pubertal suppression. Suicidal ideation odds ratio was 0.6. Suicidality, both in the last 12 months as well as lifetime suicidal ideation was less, as well as severe psychological distress. So there was no difference between attempt in suicide or things like drug use or binge drinking, but these are really important things, that the significant reduction in suicidal ideation and severe psychological distress, those are major quality of life issues. And some of them fell apart in the multivariate analysis, but suicidal ideation lifetime remained highly significant, even in a multivariate analysis. Now, this is the detransition question that comes up. Say people say, oh, we're worried about detransitioners. This is a study where they actually asked people if you've ever thought about detransitioning. This is again from a large database that was collected. And so you can see here, I'm going to just kind of highlight with this for you. The basic take home is that when people detransition, it's usually not because they decided they weren't trans. it's usually because it's difficult to blend in as the identified gender, financial reasons, it was too hard, lack of support, legal or medical reasons, pressure from different factors, sports-related reasons, can't access hormones. Now you look in here, fluctuations in identity or desire was 10%, and or something else was 2.3%, uncertainty around gender was 2.4%, but only something like 2% of the total sample had only fluctuations in gender identity as the reason for detransitioning. Pretty much of all the people who either detransitioned or thought about detransitioning, something like 97, 98% of them, there was at least one external factor. So there are many, many pressures that drive this. It's also fairly rare in general, and it's definitely not the primary public health issue that's facing the trans community, as I've kind of talked to you about many of the other factors that are facing. So this detransitioning thing has kind of been turned into a political hot potato that's been used as a wedge issue as well. So let's talk about in kids, one of the concerns that does come up when you're giving kids hormones or blockers is bone density, right? So there is an issue where we're seeing baseline bone density is low, is more likely to be low in trans kids, both designated male and designated female at birth. And if you look at this particular study, the one place, so let's do some evidence-based medicine again. There's a whole bunch of numbers and stuff, but we only have 30 seconds to look at this slide. So just look at the p-values. Okay, this is the only statistically significant one. It's less than 0.05. So let's look over here. And this was a physical activity score. So there was a significant difference in the physical activity scores between the low and normal bone density groups in this particular study of looking at baseline bone density before treatment. So before we worry about the effects of puberty blockade and hormones on bone health, we need to worry about why are these kids starting off with lower bone densities. And we think it's because there's lower levels of physical activity, which is related to some of the stuff I talked to you about. Binding and kind of discomfort with your body. So again, they're also finding there's a lot of baseline vitamin D deficiency. So this might relate to eating disorders and diet manipulation relating to body dissatisfaction. It may also relate to lack of physical activity as less outdoor activity. And in this particular study, after they linked these kids to care, they actually got their vitamin D levels improved over time. But you will notice that across the board, and you can see here, here's your p-values. These were all significant here. There was a decrease, and this is the pre to post change for both trans males and trans females on median 352 days of GnRH analog. There was some loss of bone density. So the jury's out on exactly what is going on with bone density. But the most important thing is that the solution should not be not to offer this care. The solution should be, let's figure out what's going on with bone density and do something about it. So let's pivot now to the other end of the age spectrum and talk just briefly about some data of things that face trans elders. And this was from a qualitative study. And I think a lot of this is kind of intuitive and would make sense, but sometimes you have to prove that water is wet and do some research, publish some things. So things like fear of mistreatment, isolation and loneliness that's exacerbated by trans identity, increased vulnerability to financial stressors, perceived lack of agency, healthcare system and provider inclusivity, giving back to one's community, and embracing self-truth as a path to fulfillment. So these things all make sense, and I think that they really apply to elders across any identity, but these are definitely things that are going to be swirling around in the world of trans elders who come to see you for clinical care. So I think what I'm going to do, just kind of in the interest of time, I got a little ambitious. No matter what I do, I always, there's so much to cover in this field that I think what I'm going to do, I'm going to put this citation here and take a look at it. It's very interesting. I was going to show you some tables from it, but it's very dense data. I think what I'll tell you, if you're interested and you can screenshot this, I think what I'll tell you is looking at diagnosis in Medicare databases. So looking at kind of Medicare recipients, so generally an older population, pretty much across the board, there are increased rates of just about every health issue in the trans population compared to cis populations. In some things like HIV in particular, the disparities are quite high. But there are disparities pretty much across the board in a range of cardiovascular, metabolic, and general health conditions and outcomes. So if that kind of thing interests you, this is a good paper to take a look at as a launch point. I want to talk briefly about cervical cancer screening. This is a study that I actually conducted as part of a larger study that I was involved with, and this was my primary analysis, where we found that if you had any receptive penile vaginal sex, this is a sample of 126 transmasked people. Among people who had penile vaginal sex receptive in the last 3 sex partners, they had an odds ratio in an adjusted model of 5.23 of having a current high-risk cervical HPV infection compared to people who had no penile sex in their last 3 partners within the last 12 months. So the take home here is that we have a significant disparity in the rates of cervical cancer screening among transmasked people compared to cis people, and there's lots of reasons for that disparity. But a take home is that this can kind of inform patient-centered approaches to screening, including alternative approaches to screening that we're in the process of developing here for patients who refuse screening. And we really need to be moving more towards a behavior-oriented, individualized approach to screening, especially in the era of HPV vaccination, where there's growing herd immunity. We also are going to be seeing very soon in this country, self-swabbing for HPV as a primary screen is coming very soon. It's already being used in Europe. And so that's another opportunity that is going to present itself for screening for people who are uncomfortable with a pelvic approach. Let me just quickly touch on a couple of other topics here, and then we'll go to Q&A. I just really wanted to leave you with what do you do when you start hormones? It's pretty straightforward. You put people on estrogen and you put them on an androgen blockade. There's a patient-oriented approach that you would take to using hormone therapy. You listen to what the patient's goals are, and you try to initially take a best guess based on, there are some tables in the UCSF transgender guidelines for starting dosage based on the patient's goals, and then you would titrate accordingly. Testosterone, you just use one of several forms of parental testosterone. Again, there's a bunch of tables in the guidelines online. You can take a look at them and you may find them useful. I would love to talk more about this, but we just don't have enough time, unfortunately. So I only put a couple of slides in here. And then the clinical endpoints for hormone therapy for patients who are seeking binary transition or kind of maximal effects. You really want to target testosterone into the female range, and then you add back estradiol also in the female range, arguably at the lowest tolerable dose. And then you target the testosterone in the male range, and you don't worry about the estrogen. In transmasked people, you just don't really have to worry about their estrogen levels. For patients who are seeking submaximal effects, you really kind of make like an initial, somewhat subjective art of medicine best guess at first. And then you monitor their labs and you show the results with the patient, discuss what the labs mean, what's going on in their body, and monitor for changing goals over time. So very patient-driven, but there's not any magic to it. There's no secret sauce. It's very straightforward. There's no like special regimen, or it's very straightforward, kind of almost cookbooky. And you can take a look at the standards of care or our UCSF guidelines for guidance. So this is the last thing I want to touch on, and then we'll go to QA, which is cardiovascular metabolic disorders. The general philosophy is, some people say, oh, well, hormones, is there an association with cardiovascular risk or blood clot risk? But the psychosocial benefits of hormones may include some positive lifestyle changes that actually can have a benefit for metabolic risks. And we also have to remember that the role of minority stress in the development of chronic health conditions. And basically this is, if you don't give somebody hormone therapy because you're worried about cardiovascular or thromboembolic outcomes, are you going to actually, through a minority stress pathway, because you're continuing distress and unaddressed gender dysphoria, cause them to have chronic inflammatory conditions and develop cardiovascular bad outcomes through that pathway? So, I'm going to skip this because we talked about it, but this is the last thing I want to talk to you about, and then we'll go to Q&A. We're kind of short on time. I went a little more into detail on the legal and the PED stuff because it's just so topical right now. It just, even the last week, there's so much going on. So forgive me. So this was a great study that looked at cardiovascular outcomes, looking at chart data at 3 Kaiser sites in northern Southern California and in Georgia. And they created 10-to-1 matching control groups of cis males and cis females, and they had groups of trans females and trans males on hormone therapy. There's a lot in this slide. You can ignore most of it. I'm just going to tell you the take-home points, and then we'll go to Q&A. So if you notice here, everything I highlighted in yellow is a statistically significant difference. So you can see here that for thromboembolic disease, there was a difference, hazard ratio of 1.9 for trans women compared to, and I corrected it for them, cis men, because we shouldn't be comparing men as trans men. We should compare trans men and cis men. And then also there was a difference between cis women as well. So that's noteworthy. But what's also interesting, we'll go back to that in a moment, there's no difference between cis men and trans women for stroke or MI. And for this group of people, who most of them started hormone therapy as adults, we really should be making the comparison to the birth assigned sex group. In the future, when we have most people who have started hormone therapy as kids, we might need to make the comparison group more appropriately cis female. So, okay, so let's say, all right, so we're not too worried about differences in MI or stroke in this cohort, but what about that blood clot risk, 1.9? That's pretty high, but if you calculate the number needed to harm, which is the most important thing to do when looking at ratios, is to calculate the number needed to harm, which they didn't do in the paper, but I did that for them. The number needed to harm is 111. So the overall prevalence of thromboembolic condition is pretty low in the general population. So if you have a 1.9 increased hazard of having that, it's still going to be pretty low, which translates into a relatively high number needed to harm. So remember always, the number needed to whatever is the most important thing to look for. In this case, we're looking at bad outcomes. So we're looking at the number needed to harm. So in general, from a cardiovascular perspective, this stuff is pretty safe. There's no yellow on the trans mask slide, meaning none of the differences were statistically significant for either group. So this is also very reassuring. So I'm going to stop there. And I know that I threw a ton at you. And we'd love to have, for learners, come down and spend some time with us in clinic. And we're here. We have e-consult at the health system, and always happy to help. And we're very happy to have Sen as part of our team. And I will turn it over to Sen to lead the Q&A. Thank you.
Thank you so much, Maddie, for going through this wonderful overview of our the medical system and the legal system. Just some questions just to go through. I know we are shorter on time. Some of our trans elders seem to be the most savvy internet searchers. How do you work with patients who change their own doses based on what they read online?
Yeah, that's a $64,000 question that we're actively working we have a lot going on in this area right now. It's a combination of patient education and just, I think, staying on message. I think that we all get asked to prescribe amoxicillin for colds, and we all get asked to prescribe other things for things that we know we really shouldn't be prescribing. And I just encourage folks to take that same tact for the trans community. My community deserves the same high quality evidence-based care that other communities or people with different health conditions receive. And so if you just acquiesce and prescribe whatever the patient wants, it's actually not really helping the patient, nor is it helping at the population or community level, because that patient's going to go and tell their friend that their doctor prescribed this, and then that patient's going to go ask their doctor, and then they're going to say, well, my friend gets this from their doctor, and then that doctor's going to say, okay, I guess we'll do that. So not an easy answer, but it is a thing. And there's a lot of stuff out there on the internet of some really strange ways to do this as well.
There seems to be like a pendulum of there's this trend of like gatekeeping in the past possibly, and then now things are kind of moving towards a just prescribe everything that the patient wants. And so there's that balance, I think, that you're commenting on. The other question I see here is, might you comment on the Tennessee/Vanderbilt health record issues that have not been widely covered in the media?
Yeah, I don't know too much about it. I don't know much about it other than I think Vanderbilt was required under some statute to release health records to the state government regarding patients who were given transgender care with a state-funded health plan. I don't know anything else about what's going on there. It sounds kind of sketchy, though.
Gotcha. And then another question here. We have patients on testosterone and oral contraceptive pills. What are the hypercoagulability risks in these patients?
Yeah, so I'm assuming these patients are on OCPs for contraception purposes. Sometimes you can use contraceptive hormones of a range of types to manage transmass people with complicated issues like endometriosis or persistent menses. But assuming it's for contraception purposes, I wouldn't consider any additional thromboembolic risk from testosterone being added to the mix, though I might, my personal preference is to steer away from combined oral contraceptives for people cis or trans, and I tend to prefer LARCs or non-estrogen containing forms, but for people for whom combined oral contraceptives are the first choice, testosterone would not add any additional risk. You would just use your kind of med eligibility criteria or whatever set of guidelines you like to follow when choosing contraceptive hormone therapy.
Wonderful. And I know we're about a minute to time, and I think we generally want to end before so people can get to clinic. But for those who can stay on the call, do you have any final words of wisdom for people on the call today?
Yeah, you can do this. Family docs do everything, and this is considered to be part of everything. So you can definitely do this, and read the guidelines, and do it right, and your patients will love you for it. And I can stay on a little bit, a couple minutes, and you can also, I'm happy if there's like a backlog of questions we didn't get to because I went long. You can email them to me, and I can respond offline, and then we can see if Roy wants to circulate it or whatever. I'm happy to do, whatever we need to do.
Wonderful. Well, thank you so much, Maddie. It sounds like for those who can stay on the call, it sounds like we can stay on the call. And we're all doing our virtual applause. So thank you so much.
Thank you. Yeah, I can stay till 1:05. I think that should be fine. They're rooming my next patient momentarily.
Wonderful. Well, going through the additional questions, let's see, there's a question about, autism and gender dysphoria. Can you say more about autism and gender dysphoria?
Yeah. So I'll tell you my personal opinion about this. I am familiar with the data. This may ruffle a little feathers, but I feel like it's kind of a nothing burger. I feel like there's a lot of interest in co-occurring autism and gender dysphoria. I just feel like it's yeah, so what? I think it's important to understand it because I think working with trans people when autism is present, or working with autistic people when gender dysphoria is present, may require a certain set of kind of specific skills when it comes to providing behavioral health for these folks. But I feel like sometimes the discussion around neurodiversity and gender dysphoria veers into this kind of weird place of and there's also a lot of trans people there too, or that there's the stigma for both. There's stigma for being neurodiverse, and there's stigma for being trans, and then it kind of gets mushed together. And that makes me uncomfortable. I don't feel that's a very useful framework. And that I'll tell you my opinion, and this is an opinion, is that I don't even know that you're more likely to be that trans people are more likely to be neurodiverse. I don't think there's any data that supports that notion. I think the data that exists supports a notion that people who are out as trans are more likely to be neurodiverse. But we don't have any data on what's the actual population of people who are trans total, because there are lots of people who never come out as trans. There's a high social cost to coming out as trans. Neurodiverse people may be less concerned about the social cost of coming out as trans, because neurodiverse people tend to be maybe a little less plugged into being concerned about what people think about them. So I think that there's a lot more that needs to be looked at, and I think that sometimes that discussion can flirt into a stigma-y place. I think it's important to explore it as long as it steers clear of the stigma-y place and it's in an affirming context.
Wonderful. Thank you, Maddie. And it sounds like from our tech support, we should end right at 5:05 or 1:05, excuse me. The other question I see here is, we seem to have patients wanting subcutaneous estrogen versus IM. It seems like what some people are doing. Are there any dose adjustments that you'd suggest?
No, I use sub-Q almost universally now. And so if you're checking levels, which you should be, especially when doing injected estrogen, you just titrate accordingly. And what we do in our clinic is we use like peak and trough levels rather than a random. So that, and then, you know, it gets a little eclectic, but basically the goal is to keep their estrogen from going too high above the physiologic range after peak. And then also monitor the patient for symptoms of ickiness that would suggest that their level is getting too low before their injection, and then kind of adjust accordingly. So if you switch from IM to sub-Q, you might just want to check levels a couple of months later and adjust accordingly. That's all I would do. I wouldn't make any upfront dose adjustments. I would just change the route and then check their levels after that.
Wonderful. And is there an estradiol range number that you would kind of aim for? Or
yeah. So the Endocrine Society guidelines, want estradiol level less than 200. Sometimes that can be fussy to get to with injection. I'm not a fan of injected estrogen. There's no benefit, and it's very fussy to deal with. And then the patients never get their labs, but sometimes it's hard to keep the estrogen level below 200 on injected estrogen and not have them tank out before their next injection. So I'm kind of okay into the mid 300s for people on injected estrogen, or in general. I'm okay with low mid 300s. The Endocrine Society wants it less than 200. Standards of WPATH is similar. I'm okay with a little bit over, but not too much.
Well, I think, Maddie, that's probably all the time that we have for questions. So thank you everyone for joining our call. And it sounds like these will be posted, this recording will be posted online. So if your or other colleagues would like to review it, it should be there for everyone to review. Thank you so much.
Thank you, everybody.
Take care.
Bye.